Okay, so now we're moving on to the list of the bone tumors that you can get. Right here, they jump right into osteosarcoma in the CK book, and that's pretty much the only one they really talk about. Um, this is definitely a huge topic, very high yield, but it's also probably one of the easiest ones to really understand and catch. Bone tumors, just as it is with any other organ system and the tumors you can get, it's hard because there's so much overlap between the various tumors, right? So you can get all kinds of weird questions, and then you end up not really being able to tell which one is the correct answer. Osteosarcoma, although a rare tumor, is the most common primary malignancy of bone in children and adolescents. It tends to occur in the metaphyseal regions of the distal femur, proximal tibia, and proximal humerus. It often metastasizes to the lungs, and adult osteosarcoma is often a result of sarcomatous transformation of other benign tumors, including Paget disease, which is always a problem. So this is Paget disease of the bone. There's Paget disease of the breast and other things as well. Presents as progressive and eventually intractable pain that worsens at night. Constitutional symptoms such as fever, weight loss, and night sweats may present, which often makes the question harder, because if you have a person with bone pain and fever, then you have to have osteomyelitis on the differential, infection of the bone. Erythema and enlargement over the site of the tumor may be seen. In the endocrinology chapter we're going to see later on, right? So previously in when we were doing endocrine, we saw the osteosarcoma versus Paget disease conversation already. Here they're just saying to make sure go revise that, so we'll go back and take a look at it again. So how do you diagnose this? Well, with almost everything about bones, the diagnosis is usually going to be the same here too. X-rays, right? That's how you see the bone. And when you do it, you see this thing called the Codman triangle, where the periosteal is having new bone formation at the diaphyseal end of the lesion. Or they also call it a sunburst pattern. So that's what they're showing you here. Now, the sunburst thing is the easier of two. Right? So image A, osteosarcoma, femoral X-ray shows the typical sunburst pattern of osteosarcoma. Definitely the easier of the two lesions to catch. When you see this sunburst thing happening, you just think osteosarcoma and you're done. This, not so easy. So what they're showing you here is that there's new bone development. Right? This is for Ewing sarcoma. Characteristic onion skinning of Ewing sarcoma is evident in the proximal femur in this X-ray of the left hip. Right? So in all honesty, it's not that obvious. A lot of the images that CK uses in their first aid CK, they're not that good. So we're going to go back and look at it in the step 1 book as well. They go on to say, in contrast to the multiple layered onion skinning that is classic for Ewing sarcoma and the soap bubble appearance of giant cell tumor. Right, so giant cell tumor of the bone here. This is pretty obvious. This is nice. This is a good image showing you that there's some level of emptiness here. Right, so that's the soap bubble lesion they're talking about. So the cancer is like within this region. Now, with bone tumors, the big differentials is going to involve how does it look and where is the tumor? Where on the body is it? The metaphysis, the diaphysis? Which bone is it in? The arm, the leg, facial bones, etc. Most accurate test is to do a biopsy if possible, and then CT of the chest facilitates staging to see, for example, if there's any soft tissue and bony invasion. Patients can also present because of metastasis to the lung, as they said here. Right, metastasize to the lungs. So, oftentimes the bone pain alone isn't enough to get patients to come in. They'll just take like medications like Tylenol or something, acetaminophen, and then they'll survive off of the pain medications and just be fine. But once it metastasizes to the lungs, it gets a little worse of a problem, and you need to be making sure you don't look at their lung problem as a primary lung problem, right? And that understand that whatever's happening to them metastasizes from somewhere else. Treatment is limb-sparing surgical procedures and pre- and post-operative chemotherapy with medications. Amputation may be necessary. So now, if we come back to the step 1 book, here they do a far better job listing out all of them, because even now in step 2, there will be questions regarding these guys. You get questions on all of them. So the primary bone tumors that are benign are all of these. Okay, these are named in a way where you can kind of identify what's happening, and you shouldn't have too much confusion. But it is very annoying that there's so many. That's always going to be the case. It's always annoying when there are more than 2 or 3 to memorize, right? So the first one here, osteochondroma, right? So osteo, we know that's just bone. The word having con in any of these names tells you that it's cartilage related. Right, so osteochondroma, this is the most common benign tumor in young males. Okay, it occurs in the metaphysis of long bones, and what you see is this cartilaginous cap. Right, so that's why I wrote, imagine a young man wearing a cap. Rarely transforms to chondrosarcoma, which isn't something you need to really worry about too much. But identifying this cartilaginous cap is going to be everything. So let me show you the picture, like this right here. Right. Because once you see that, you just know what's happening. So this little flared up region right here is basically the cap they're talking about. It's like there's a hook here, and you hang your cap on the hook, something like that. X-ray, radiologists are very creative with how they describe many of the things they describe. So that's what they call that. They call that a cartilaginous cap. So osteochondroma, young man with a cap. Very straightforward. There's nothing else you can really look for there. Osteoma is actually relevant for something we've already looked at, which was the Gardner syndrome in GIT. Remember in GIT, Gardner syndrome was familial adenomatous polyposis plus the involvement of osseous and soft tissue tumors. They also had messed up teeth, right? So remember the mnemonic or the statement we made was that you should guard your teeth, right? That was the thing with Gardner. The other thing was Turcotte syndrome, which was Turcotte for turban. That one had CNS tumors along with FAP. So osteoma is just an FAP thing. Right? You're not going to see osteoma as just an osteoma. It's almost always, or 100% of the time actually, forget usually and almost always or whatever. Not a fan of saying that because it doesn't help, right? It's always going to be a question about someone with FAP who has soft tissue tumors. Then you just pick osteoma. That's it. The osteoid osteoma is a whole different thing. So these two guys get compared to each other, number 1 and number 2 here. Osteoid osteoma and osteoblastoma. These two get compared to each other. Osteoid osteoma is actually a tumor in the cortex of long bones. Also occurs in young males for the most part. So same group of people as osteochondroma, young males under age 25. But the location is different, right? So let me actually see where I put that image. Oh, right here. Okay. So here you see I labeled where the different parts are in case you didn't know. So this region here of any bone, this region and of course on the other end also, is called the epiphysis. The metaphysis is right next to it, and then the diaphysis is basically the more central part of the bone. Right? So you do need to know, what the different terms are for labeling the parts of a bone. Okay, so what we're seeing right now is that osteochondroma occurs in the metaphysis of long bones, right? So that's literally right here where pretty much all of them occur. Okay, and then the osteoid osteoma, though, this occurs in the cortex of long bones. It's not in the those 3 regions or anything. It's in the main cortex, which, remember, let me see, right here. See, so they put it, the cortex being always the outer layer, right? Cortex and medulla of any, like when we were in endocrine, the cortex and medulla of organs was cortex being the outside and medulla being deep inside, right? So like fibrous dysplasia is occurring in the medulla of the bone, for example, right? So it occurs in the cortex, it's right outside, and it has some special characteristics. So in your question, what you'll see is that the patient is probably some 14-year-old who has like pain in one leg. It gets really bad at night. It's not related to any trauma, and it's relieved by NSAIDs. So there's a special thing about this osteoid osteoma. This is a tumor that actually makes a lot of prostaglandins, right? This is not written here, but it's actually in one of the UWorld questions, and it's explained in that manner. Right? So it makes a lot of prostaglandins, and taking NSAIDs actually helps relieve the pain of this osteoid osteoma. It's tiny radiolucent osteoid core lesion right at the cortex of long bones in young men. This is compared to osteoblastoma because this one also looks very similar, occurs in men, but the location is in vertebrae, not in the cortex and long bones, and it doesn't really get affected by NSAIDs, unresponsive to NSAIDs. So since it's in the vertebra, this could be a person with back pain, right? This could be a person with upper back pain, which is extremely rare. Almost all people have lower back pain if they have back pain, but never upper back pain, right? So when you get upper back pain because there's a tumor in the upper vertebra, then you really need to consider what the heck is wrong. And back pain is really debilitating. So people take NSAIDs or whatever else they can for the pain, but the NSAIDs will have no effect here. All right. So that's all four of these so far. Now we looked at osteochondroma. Then you have a chondroma. So osteochondroma actually did involve the cartilage of bones. You had cartilaginous cap on the bone. So it's osteochondroma. A chondroma doesn't really involve the bone at all. It's just going to be a benign tumor of cartilage itself, medulla of small bones, or hand and feet. That's it. It's just a bunch of cartilage, but it doesn't necessarily occur on big bones or major bones or anything. There is a picture for that I found. Let's see, chondroma right here. See, it doesn't involve major bones. It's just cartilaginous cancer. Right? Very, very, very rare thing. Not only in real life, but also extremely rare in exams. All right, so chondroma versus osteochondroma. Last thing is this osteoclastoma, which compares to the osteoblastoma. Right, so osteoblast and osteoclast. Osteoblast right here was the one with that causes pain, that's unresponsive to NSAIDs. Osteoclastoma is also called a giant cell tumor. This is also extremely common in questions. Occurs in the epiphysis of long bones, often in the knee region. Locally aggressive benign tumor, neoplastic mononuclear cells that express rank ligand, and reactive multinucleated giant osteoclast-like cells. You get a soap bubble appearance on X-ray. So remember that osteoblasts make bone, right? And osteoclasts break it. So the reason you get this soap bubble lesion is because there's a lot of osteoclasts here and they're breaking the bone. That's why it's so empty and translucent. Right? So when you see these X-rays, you need to be able to call out what's happening in each of them without really needing to check, for example, right? So this thing in image B is your osteoid osteoma. This is going to be the one where you give the NSAIDs and they feel better. So notice the key difference between B and C. In C, you destroyed a lot of the bone in this region, so it's very radiolucent. Over here, you have this hole, but then the rest of it is very bright because they're making more bone. Right? They're making a lot more bone in this one region. They're also making a lot of prostaglandins from the osteoid osteoma, and treating it is going to be pretty intense work. Right? They didn't really talk about what those arrows are, though, right? No, they didn't. There's a white arrow and a black arrow, but they didn't break down what the white and black arrows are about. Alright, so that's pretty much all of these guys, right? So now, of course, going over it one time is, as usual with everything else, not going to be enough for you to memorize this and have it down perfectly. But it's definitely something you need to know, unfortunately. You have to come back to it a couple times to get it down. Even after studying it a few times, there were times where I would get a question about someone who had an osteoid osteoma and not really figure it out. But the more times, remember I said that every time you're doing you're doing UWorld or AMBOSS or any QBank, when you do a question, you should spend time coming back to first aid to make the connection, right? That's the quality part of doing questions, as opposed to just doing 40 questions and making it a quantity thing and then not really revising and mastering those topics. So when you do questions about this stuff, make sure you come back here and look at the notes, right? And add anything if you need to in your book, because there is a little bit of space here, there's some space here. If you need to add any extra notes, go for it. When you find more questions about these things, annotate it. It'll help you study and memorize that even better. Right? So osteochondroma, osteoblastoma, osteoclastoma. Cartilage on bone, that's your cartilaginous cap. Osteoblastoma is making more bone and NSAIDs can't help. Osteoclastoma is breaking some bone and it starts looking like a soap bubble. Right? Then you have the other guys, osteoma. This is just associated with FAP. Osteoma and FAP, and then Turcot, So Gardner and Turcotte, that's it. Osteoid osteoma is the one that's making a lot of prostaglandins. You need to give NSAIDs and they'll feel better. And then you're done. That's it. Don't really worry about chondroma too much because this really isn't something I've ever seen in a question, nor does it mimic any of these other guys. So if you do get a question about someone who just has cartilaginous tumors all over some hand or something, then you would just pick this as an answer choice. It's not a difficult differential. It doesn't match any of these other guys, so you just pick it, if that's what your question is doing. This question here, a 52-year-old woman comes to the physician because of lower back pain for 1 week. The pain is constant, severe, and dull in quality. Alright, so lower back pain, but in a female. Pain, and this is pretty rare. Usually if you get a lower back pain question, it's going to be a male, and it's often related to prostatic cancer or something. Or if it is in any gender, it's usually related to their occupation and lifting things that they're not trained to lift. She does not recall any trauma to the area and has not had any urinary or fecal incontinence. She has had a 20-pound weight loss over the past 6 months, so losing weight pretty aggressively without really trying to. Physical exam shows localized tenderness over the lumbar spine. An X-ray of the spine shows vertebral compression fracture at the level of L1. Further evaluation of this patient is most likely to show which of the following findings. And the answer was spiculated density on mammography. Now, compression fracture is usually related to osteoporosis, but here they tell you unexplained weight loss and a pathologic fracture of the vertebra with no history of trauma should actually raise concern for an underlying malignancy that has affected the spine, right? Just having the vertebral compression fracture but not the weight loss would be more osteoporosis. In this way, with the cancerous presentation of extreme weight loss without really trying to lose weight, it doesn't look too good, right? That looks really problematic. Breast cancer is among the most common malignancies that metastasize to the bone, along with lung cancer, thyroid cancer, renal cell carcinoma, and prostate cancer. Bone metastases from breast cancer can have both lytic and blastic features. Right, so right here we looked at primary bone tumors. Metastatic disease, though, is more common than primary bone tumors. Benign bone tumors that start with O are more common in boys, which is not really the best thing to memorize, but sure if it helps. Because this one also is called an osteoclastoma, and this question usually is actually in women. So gotta be careful with that. Now, this metastasis stuff, as you can see over here, we've looked at this before. Very high yield stuff, very critical, very important in utilizing to kind of get the correct answer. And I made up some things here to help memorize this better. We actually just recently looked at this when we were looking at Hodgkin and whatnot lymphomas and how they metastasize to the bone, but we finished hematology and oncology. So you see bone lesions in general can always be osteoblastic or osteolytic. When it's a bone metastasis, it also can be osteoblastic or osteolytic depending on what cancer is metastasizing. Prostate cancer, small cell lung cancer, and Hodgkin lymphoma all cause osteoblastic lesions, which means there's more bone being made. So I made up the term blastate for prostate and small blast cell. Right, it's about a small cell lung cancer, small blast cell lung cancer. So those are both going to be things that are osteoblastic. Osteolytic lesions come from multiple myeloma, non-small cell lung cancer, non-Hodgkin lymphoma, renal cell carcinoma, and melanoma. So here we have Hodgkin, this is non. And here we have small cell, this is non-small cell. So the non-things are all causing osteolytic lesions, which in my mind I memorized that as no cells being made, no bone being made, right? Non for no bone being made, because this is breaking bone, it's osteolytic. So non, and then the kidney, thyroid, and myeloma are all lytic, with the guys that have the Y in it. I spelled kidney with the Y even though it doesn't have a Y in it. Like, not over there at least, right? Very important to have this down. Very important to have this down because you're gonna be asked what's happening. You could get a patient with a question where they have multiple myeloma, and then they also have a bone lesion. But then if the question tells you that the bone lesion is osteoblastic, then their bone lesion is not due to the multiple myeloma. That's the kind of shit you can get in questions that you have to be prepared for. Similarly, you could also get a person who has both multiple myeloma and prostate cancer. Right? And then if they tell you in the question that the lesion is osteolytic, then you know that it's the multiple myeloma that caused it, not the prostate cancer. So you have to know which one causes which. You have to make up things and memorize this the best as you can. Mixed lesions are from GIT and breast. Alright, so mixed meaning two types, so osteoblastic and osteolytic, and there's two breasts, so that works. And then GIT is a whole bunch of things, so colon cancer basically will cause mixed bone lesions, right? Because in your GIT, food mixes, so you're going to get mixed lesions. All kinds of ways of memorizing things. You got to do your best you can. Here I've described what the lesions look like in X-ray. So an osteolytic lesion is going to be see-through, radiolucent. Osteoblastic lesion is going to be sclerotic, which is really bright for most of the time. Right? Here we're seeing a bunch of these, right? So this one here has this like singular thing in the skull, right? This is an anteroposterior radiograph of the skull demonstrating a smooth radiodensity lesion of an osteoma. Right? That's all this is. It's just an osteoma. Remember what osteoma was? Coming back here, just this one right here, which was related to FAP. Right? So let me come back here. So this is going to be someone who most likely has FAP. To the right is an anteroposterior radiograph of the right leg demonstrating cortical thickening of the mid-right tibial diaphysis with a central lucent lesion in someone with osteoid osteoma. So the cortical thickening, first of all, remember it involves only the cortex being the outer lining, right? The outer lining. So if we look at the outer lining, they drew it pretty perfectly right here. It's on the outer lining, osteoid osteoma. So if we look at this X-ray right here, same thing with this guy too. This is a guy with osteoid osteoma and is developing right here. You see this area that's a little thicker right here. Let me undo the red and then you could watch it. Right, so this part right here is a little weird, and that's where the osteoid osteoma is. Right, this is cortical thickening. The cortex is getting thicker here. Right, so that's someone with osteoid osteoma where giving NSAIDs will definitely make the pain go away, but they might need amputation for fixing this. Primarily, you'll try to get in here and maybe see if only a part of the bone can be breaking off, or just replace this entire bone with a metal replacement, but it's very hard. It's very hard to see what would actually work. Oftentimes, another procedure, you know, if this isn't all cancer, if this isn't all cancerous, right, then what you can do is, if it's just this region right here, then what you can do is cut here and here, trash this middle area, and replace that middle area with metal. Right, so that's another option. But again, like, it all depends on how much metastasis there is and where things are moving. Okay. On the left over here we have osteochondroma. Right, osteochondroma, which is, remember the osteochondroma was cartilage on the bone. So you have this little cap again, right, where you're hanging a cap on a hook. Right? It's a tiny growth that kind of sticks out, and that growth is all cartilaginous growth, so it doesn't look like bone. Right? It's not bright, it's not all white, it's kind of all see-through and white. It's a mixture because it's cartilage, it's young bone. It's a chondroma, right? And it can occur in this region, which is your metaphysis, right? Not the epiphysis. Yeah. Right? So the osteochondroma and the metaphysis. Epiphysis is where the connection is going to occur with the other bone. Right? Metaphysis is this region over here, then you have your diaphysis. So always you're seeing it's either the metaphysis of some arm bone or metaphysis of some leg bone. This one down here, you get your beautiful sclerotic lesion. You're making a lot of bone here. That's osteosarcoma. Right? That's an osteosarcoma in a patient. We haven't looked at it right now, but we read it in the CK book. So here are your malignant tumors. There's three: osteosarcoma, chondrosarcoma, and Ewing sarcoma. You know they're malignant because the name has sarcoma in it. Osteosarcoma has this really nice sunburn pattern, or sunburst pattern, excuse me, which is also often referred to as the Codman triangle. Right? So this Codman triangle thing is an elevation of periosteum, right? Because you're making so much bone to kind of lift it up, and you can see this outside too on the person's leg. Of course, if your bone is lifting up, the skin above it is also, and the muscle around it is also pushing out. So their leg looks really weird. 20% of primary bone cancers, peak incidence is in very young males and is often related to other predisposing factors: Paget disease of bone, bone infarctions, radiation, familial retinoblastoma, and even leishmania. The histo part you don't need to worry about. This was more prominent in step 1. But they could describe that they did a biopsy and they saw pleomorphic osteoid producing cells. So pleomorphic is pretty malignant, and they're making osteoids, so it's a cancer that's making cells. So these are malignant osteoblasts. Osteosarcoma is a malignancy of osteoblasts. Whereas over here, osteoblastoma was benign. Is the one that doesn't respond to NSAIDs because it's making bone. It's not making prostaglandins, it's making bone. So it doesn't respond to NSAIDs and it hurts. It's painful. It occurs in the vertebra, causes upper back pain. Could be lower back pain too, but to differentiate this from other things, they'll probably, hopefully, give you a question where it's causing upper back pain, which is an extremely rare thing, doesn't really occur to everyone else. Alright. Chondrosarcoma and Ewing sarcoma. So chondrosarcoma is, as you could tell, a tiny thing right here. They just put it here because you do need to know it. This is also referred to as an N chondroma. NBME21 had a question on it. The only thing is there is similarity in them. You have to be able to differentiate them. The only thing here, look, I wrote N chondroma is the same on histology but affects the hands and feet and are cyst-like, right? Cyst-like. So this was an NBME21 question for step 1. Chondrosarcoma occurs in the medulla of the pelvis, proximal femur and humerus. So now it's in the medulla, which means that it's going to be in the central region. In the central region over here somewhere, right? So that's very unique because most of these are not going to be in the medulla. So you need to catch that, and it's actually a malignancy of chondrocytes, which make cartilage, right? So we got the malignancy of osteoblasts, we got the malignancy of chondrocytes, and then here we have Ewing sarcoma. So this guy is here because there's actually a translocation related to it, right? 11 plus 22 gives you 33, which is Patrick Ewing's jersey number. That's him. Translocation 1122, which fuses the EWS with the FL11. You don't need to worry too much about what they are, but I did write it, not FL11, FLI1, excuse me. FLI1, so here I broke down what they do. EWS encodes an RNA binding protein, also known to be associated with ALS. FLI1 is friend leukemia integration 1, which is also a protein for erythroblast differentiation via the RAS pathway. Their connection is absolutely nothing. The two guys are not related to anything at all. But what happens is every time, so once this translocation occurs, every time you make this transcription factor, you also make the EWS issue, and that is the issue that's causing the cancer. Right? So most translocations are only problematic when you move something you never transcribe next to something you always transcribe, because now you're transcribing both together and you keep making this bad thing that you're never transcribing. Right? And this is the one where you see the onion skinning. Now, in both of these x-rays, the onion skinning is extremely evident. Even on the left, you can see it. You can see there's like straight lines coming down, like that. You know, so it's very clear there's an onion skinning happening. And then, of course, if you look at it as a cross-section, it's very evident too. Diaphysis of long bones, pelvic flat bones, and whatnot occurs in really young boys. Really, really young boys, right? You're going to see small blue cells, which is what I put here, homerite rosettes. So again, you don't need to know the histology in terms of identifying it for step 2 anymore. You probably would need to identify it on step 1. But on step 2, what they can do is they can verbally describe the histology to you. Right? They can verbally describe the histology to you, and you have to know if they mention pleomorphic osteoid producing cells, osteosarcoma. If they mention anaplastic small blue cells, Ewing sarcoma. And the malignancy of chondrocytes, chondrosarcoma. And these are named pretty well in that aspect. Let me see, is there anything else about this stuff? There's a question here, so let's see what this one is. This is a very young boy, 3-year-old boy, brought to the emergency department because of high fevers and malaise for the last 4 days. Parents say he began limping yesterday and seems to refrain from using his right leg. So right now, so far, there's a differential here. It could be osteomyelitis, or it could be that he has cancer of some sort. But being that he's only 3 years old, it's more likely that this is an osteomyelitis, especially because they said it's high fevers. They didn't give a number yet. He has no history of travel or exposure. Temperature is very high. Passive range of motion does not elicit pain, and no joint effusion is seen. So that actually kind of helps rule out cancer. Right? Passive motion would elicit pain in someone who's making extra bone or breaking bone because of some kind of cancerous thing, and there could be effusion because of inflammation. However, the patient refuses to bear weight with his right leg. Refusing to bear weight is also an osteomyelitis thing. Scintigraphy is most likely to reveal increased focal radiotracer uptake in what area? And this was actually a curveball question because up to now we're confidently sure this is osteomyelitis. But no one really knew where osteomyelitis occurs. That apparently there's a region that's most likely to show up in. So it's most likely to be in long bone metaphysis. An image describing the progression of hematogenous osteomyelitis was given, but I could not find it online or screenshot it. Hematogenous osteomyelitis affects children, particularly boys, and usually affects the metaphysis of long bones since it contains slow-flowing sinusoidal vasculature that is conductive to microbial passage. So that's the area that has blood flow, basically. Adults don't develop this due to the epiphyseal closure. Osteomyelitis may affect flat bones of the skull via contiguous spread of infection from mastoiditis or dental abscesses. So that being said, let me actually see if I can find this image. So this one was hematogenous osteomyelitis. Okay, let me see if I can find it real quick, because if it is a thing, now that UWorld is online, it should be easier to find some of these images. Hematogenous osteomyelitis, UWorld. No, not really. All I'm seeing is basically images showing that exact region, the metaphysis. So right here, there's a lot of vascularity in this region. So most images are just showing that osteomyelitis or infection of the bone usually occurs in this area also. Right, so that kind of wraps up everything you would need to know about tumors and osteomyelitis occurring in the bone in different ways. Here is a note, probably based off the same thing. Osteomyelitis affects the proximal metaphysis because the metaphyseal blood supply is unique in that nutrient artery supplying the metaphysis makes a sharp loop before it empties into sinusoidal spaces, where the rate of blood flow is decreased. This creates a medium for bacteria to proliferate and cause cellulitis in the bone marrow. Okay. Right, so it's very easy to get osteomyelitis right in these regions, the metaphysis. Right. So osteomyelitis, bone metastasis from various cancers, and then primary bone cancers. A whole topic for today, right? That's a huge thing to make sure you can, for today, master, get it down perfectly, don't have any confusion in talking about, and differentiate without any hesitation. Right? In the step 2 book, all they talked about was just osteosarcoma mainly. And then they gave you some bad images, but that's about it. So let's look at the questions they put here. There's a 23-year-old man presents to the emergency department with swollen and erythematous right hand following an altercation at a bar a few days ago. So he had a fight, and now he has a swollen right hand. The dorsum of the hand shows abrasions, and X-ray films reveal a fracture of the 5th metacarpal. What is the next step in management? So this looks like that boxer's fracture, right? The boxer's glove fracture. So what would you do for this person? So most people that I've shown that question to actually didn't really know what to do about it. But we saw a question about this earlier. Where there was a person that punched somebody and actually was bleeding too, which indicated that they might have punched somebody and gotten a tooth bite into their skin. If the skin is broken in a boxer's fracture, assume infection by human oral pathogens and treat with surgical irrigation, debridement, and IV antibiotics to cover the Eikenella infection. Right? That's the thing that needs to come to your mind every time you ever read a question about someone who had this kind of altercation. Right? They just told you that there's an abrasion, and X-ray shows a fracture. So if the abrasion was bad enough to cause a fracture, there's probably also a cut where his tooth or his teeth might have gone into the person's skin in that punch. So you just need to clear for that. The fracture itself is pretty easy to manage. That's just fracture management in general. Stabilize the fracture and let it heal and recover. But you do have to treat for the infection aspect, right? Next question here, 37-year-old man is seen after a motorcycle accident. He complains of intense leg pain, tingling in his foot, and inability to move his toes. Exam reveals pain with passive motion of his toes and palpable dorsalis pedis pulses. An X-ray confirms tibial fracture. What is the best treatment? So now, this is another person who has a fracture, but this time is due to a motorcycle accident. Right, where one of the things that's happened to him is now he has pain with passive motion, but the blood flow is good because you do have a palpable dorsalis pedis pulse. So blood flow isn't impeded, but there's a tibial fracture. So how do you manage a tibial fracture? That's what this question is asking you. And you can get this scenario during your rotations too, right? Your attending you could have a patient that shows up like this in any rotation, and your attending could ask you, all right, so what should we do? Well, immediate fasciotomy for compartment syndrome is the answer here, followed by fracture stabilization. Now, fracture stabilization is the commonsensical answer. That's the answer you can't give to your attending because they're going to laugh at you and be like, oh, really? I thought we should just toss the patient out or something. Like, of course you're going to do fracture stabilization. That's obvious. But what else do you need to worry about? Right? That was the thing here. The other thing you need to worry about here was the infection. And in this case scenario, the thing you need to worry about is compartment syndrome to prevent muscle necrosis, because what can happen is that non-palpable pulses are a late finding. Right? Non-palpable pulses. He had palpable pulses, but it's palpable right now, but it may become non-palpable later on, and that's something that you have to know. This is related to the compartment syndrome we covered earlier, right here. Right? Paralysis, and they tell you paralysis and pulselessness occur as late signs of compartment syndrome. Since he has a tibial fracture, it's very likely that somewhere here, something may not work too well anymore. Later on, though, not right now. So this is why you need to do the fasciotomy, to make sure you relieve any pressure that might have built up there after the accident. Yeah, so do immediate fasciotomy for compartment syndrome within 6 hours, and of course do fracture stabilization. All right. So that's it for that. Let's look at this next thing here, septic arthritis. So let me see, there was a table that I had. I need to move that table. Let me just grab that table really quickly because I put it in the wrong place. I was fixing up some things here last night. Oh, right, I put it in, okay. There's a septic arthritis table, but I put it in the pediatrics section because everything that occurs in peds is actually all talked about right there. Right, the entire chapter, every single chapter is here. Right, they have the heart, GIT, renal, everything under peds itself. So like the pediatric section is a book of its own in a sense. So it's okay, I'll leave it over there then. Let me see where we are. Septic arthritis. Okay, so this is just infection that presents with arthritis. An infection of the joint space that can occur after open injury or bacteremia. Prosthetic joints greatly increase the risk. Rheumatoid arthritis, osteoarthritis, and bacteremia from endocarditis and IV drug use are also risk factors. And we're going to see those when we get to these specific topics. Presents as a warm, red, immobile joint, palpable effusions because now there is inflammation. Fever and chills can be present if the patient is bacteremic. Most accurate test is just to do a joint aspiration. Very straightforward. You do the aspiration and you're going to see a bunch of white blood cells. You might even actually find what's causing the infection, and the most common things that cause this osteomyelitis basically are staph, strepto, and gram-negative rods. What's the cause of the osteomyelitis would depend on the patient. If they have sickle cell, then it could be other things, right? Remember, in sickle cell osteomyelitis per se, this isn't osteomyelitis directly, but in sickle cell patients, osteomyelitis was being caused by salmonella, not one of these things. Empirically treat with ceftriaxone and vancomycin initially until culture test results come back. Then modify the therapy for specific organisms. So you don't wait for cultures. You start treating right away with the ceftriaxone and vancomycin, and hopefully the culture brings back exactly the target of ceftriaxone and vancomycin. Septic joints are treated with joint drainage or surgical debridement. Very straightforward, right? Here they're giving you the breakdown of synovial fluid analysis, whether it's inflammatory or not, and if it's septic. So the color won't be that good. It's not going to be that helpful because you can see color can't be much of a differential here. They're all yellow, right? So it's yellow in all three cases. Viscosity is a good differential. When it's non-inflammatory, it's going to have the same viscosity as a normal person, high. When it's inflammatory, it's going to have low viscosity because now you have a bunch. So viscosity was basically the thickness of the fluid, and when it's inflammatory, there's a lot of extra shit in there. So it's going to have very low viscosity because if you look up the, let me tell you the exact definition of viscosity. Viscosity is a property of liquids that is closely related to the resistance to flow. Resistance to flow, right? It is defined as the shear stress divided by the rate of shear stress strain. They find a different definition as well. Resistance to flow, the state of being thick, sticky, and semi-fluid in consistency due to internal friction, and that's the state. So normally there's high viscosity in synovial fluid where it is very, where it is going to be very thick. And when it's non-inflammatory, nothing really changes, so it's also still going to be very thick. But when it's inflammatory, all the erythrocyte sedimentation rate and whatnot causes the viscosity to become very low. So this is one little differential point you could utilize. But the real differential actually comes from these areas, right? Very similar to when you do CSF analysis, right? Where you look for white blood cells, whether or not there's neutrophils, and how much glucose is there. So if it's non-inflammatory, actually the only real differential once again is between these guys now. You can see that when it is inflammatory or septic, the white blood cell count is going to be super high, right? And how high will tell you which one it is. So like from 1,000 to 10,000 and possibly up to 100,000, it's inflammatory, which again doesn't really cause much of a differential here because this also goes up to 100,000 and it could be septic. So it's not nothing solid yet, right? Nothing extremely solid yet, but this is pretty good because it helps you differentiate from the non-inflammatory where it's very low white blood cells, less than 1,000. Then you look at whether or not there are neutrophils there. Now, of course, if it's septic, you're going to have the most neutrophils, right? But if it's inflammatory, you also have neutrophils, just not as much, right? And the last thing to help differentiate is how much glucose is there. If it's septic, the bacteria will eat the glucose, so it's low. So that being said, the easiest one to identify from synovial fluid analysis is septic arthritis. Right, you're going to see a super extremely high white blood cell count, high neutrophils, and low glucose. Same thing with CSF analysis of septic meningitis, right? Where when it was aseptic meningitis and there was viral meningitis basically, then glucose would be normal and protein would be high because viruses are just protein, right? They're just amino acids. A joint affected by inflammatory arthritis can become secondarily infected. Right, so this can lead to this is what they're saying. Alright, so that's basically all they have here, but all in all pretty easy. So how does this even present in a question? Well, you're going to get somebody who just had a weird injury. Right? Someone, I think one question that always comes back to me is there was a question about a guy who's just like practically walking for all I can remember, and he hits his knee on a table really badly. I don't know how, but that's what he does. And that's your open injury right there. Right? That injury was enough to introduce inflammation in his joint and introduce bacteria or something off of the table into his joint, leading to septic arthritis. Right? Where the next day he became like this. And what did you have to do? Joint aspiration. But you see how this question I'm telling you caused open injury in the knee, and that same knee thing can also be other things in questions. It could be gout, it could be pseudo-gout, and many other things. So you have to be able to differentiate. So we're going to see those differentials coming up pretty soon. Where generally speaking, even in those differentials, what you would order would be a joint aspiration. Right? So the answer for CK is going to be the same. What's the next best step? Get the joint aspiration. Look at what's in there. All right. So we'll get to gout when we get there. Right now, the next topic is one of your major topics of osteoarthritis, which I have separated as a tag of its own, because osteoarthritis versus rheumatoid arthritis is a huge topic. Right? It was a huge topic in step 1, and it's still going to be a huge topic here in CK. This is a common chronic non-inflammatory arthritis of the synovial joints, characterized by deterioration of the articular cartilage and osteophyte bone formation at the joint surfaces. Risk factors include a positive family history, obesity, and a history of joint trauma. Presents with crepitus, decreased range of motion, ROM, and initially pain that worsens with activity and weight bearing but improves with rest. This is one of the major things that help you figure out what's happening. So osteoarthritis is an arthritis of excessive use. It occurs oftentimes starting in the fingers in people who have an occupation where they use their fingers too much, like in construction with screwdrivers and stuff like that. And because it's related to arthritis occurring from overuse, the resting helps you become better. Right? Resting improves the pain, but more use will worsen the pain. So in these people, in the morning when they wake up, they feel great. It's at night when they're going to sleep that the pain is the worst. Right? And then they tell you morning stiffness generally lasts for less than 30 minutes. Stiffness is also experienced after periods of rest. Right? This is going to be a thing for them. They feel better after all night, but then they have morning stiffness. Right? X-rays will show joint space narrowing, osteophytes, subchondral sclerosis, and a couple other things that don't really mean too much. X-ray severity doesn't really correlate with symptomatology, right? So it doesn't really mean too much. The reason you're doing X-rays is to possibly rule out other things that could be happening. Lab tests, including inflammatory markers, are typically normal, right? And here they're showing you plain X-rays with joint space narrowing, osteophytes and subchondral degenerative cysts involving the DIP and PIP joints with sparing of the MCP. But the question is, do you see it? Do you see all the things they're talking about? All right, where is the joint space narrowing? Where are these osteophytes they're mentioning? And where are the subchondral degenerative cysts they're mentioning? Because if you don't catch it, and it's possible you don't see it at all because we're not trained yet to see it, then such an X-ray will never give you the answer. You have to be able to catch it. If you can't catch it, then when I give you this X-ray, you're never going to pick osteoarthritis as an answer choice. You won't know to pick it. One of the big things about osteoarthritis is the involvement of specific joints, the DIP and PIP, with sparing of the metacarpophalangeal joints. Right, so how do you do this? Well, first of all, let's go back here and complete. Actually, let's finish this and we'll complete this. Let's finish what they talk about. A little bit less treatment. So when you get someone with osteoarthritis, the main thing you have to do for them is get them therapy. Right? Get them therapy. Tell them to lose weight, but they probably won't lose weight. So just get them therapy and put them on NSAIDs. Intra-articular corticosteroid injections may provide temporary relief, and you can do these corticosteroid injections for specific parts of their body where it might be hurting a little too much. Most definitive treatment, however, is surgery. Consider joint replacement like total hip or knee arthroplasty. Patients are at higher risk for developing osteoporosis when they have osteoarthritis. Because now this could be an old postmenopausal woman, a postmenopausal female, who now is developing all of this shit, right? So a postmenopausal female with osteoarthritis is at extreme risk for osteoporosis symptoms. So in such a woman, weight reduction would be extremely important, right? As we said before, NSAIDs are not always an option for people, right? And we've talked about this every time. If you're ever doing a question, this needs to ring a bell in your mind. You can't give NSAIDs to everyone. You can't give NSAIDs to people who have really bad renal problems. You can't give NSAIDs to people who have really bad peptic ulcer disease because prostaglandins are going to disappear, and you need your prostaglandins. They're protective, right? Especially in those specific people. They can't afford losing prostaglandin function. People without peptic ulcer disease and renal failure, we can easily let go of some oral prostaglandins, will be fine. But not everyone can utilize NSAIDs. So for those patients, it's best to get them to immediately start losing weight, which can be many things. Remember that there are clinics you can go to start losing weight. Right? Weight loss clinics are a thing where you would go and they would tell you about all kinds of things you can take to lose weight. Or, of course, get a procedure done. So these are the people that really need to get those bad procedures done, the gastric sleeve and whatnot. Surgeries where you no longer can eat because you took out a portion of your stomach, right? So that usually isn't something most people would prefer. It's usually middle age to, maybe up to like 45, 50-year-old women that will want to get it done. But after that point, after 50, very few women often want to get a gastric sleeve done. So then you go to a weight loss clinic, and what do you take? Well, there's a lot of medications, right? There's Orlistat. Orlistat is sold as Ali. Orlistat is a medication that ends in stat but has nothing to do with the other stat medications. It's actually a medication that causes you to not absorb any of the oils, any of the fat from the food you eat. So what happens to these patients? Well, whatever they eat, they just poop it all out. All the oils in their food won't get absorbed. And one of the side effects there is the fact that, of course, if you're losing all the fat, you also lose your fat-soluble vitamins, right? That's just one thing. There's a lot of things. You can start the person on amphetamines. Amphetamines are also going to help with hunger control and not make you hungry at all. Weight reduction could also encompass other things that the patient might have. Like if they have diabetes, you need to make sure you manage that well. If they have thyroid problems, make sure you manage that well. Anything else that can contribute to their obesity, manage those conditions as well, right? So then that might require sending them off to an endocrinologist, and so on. So now let's go back to here to get a better differential understanding between these two case scenarios, because these are extremely high yield topics with a lot of similarity to them. So osteoarthritis, mechanical, right? Wear and tear destroys articular cartilage, leading to a degenerative joint disorder. Inflammation with inadequate repair, chondrocytes mediate degradation, and inadequate repair. So it's all due to the chondrocytes and osteoclasts basically causing everything to break. Usually going to be in older females who are obese. And it could be in older obese males with joint trauma. Any combination of these things, right? In fact, this is such a big deal, the predisposing factors, that UWorld had a specific question for this. It said, what is the most significant risk factor for osteoarthritis? Of course, first they didn't tell you which one was the most significant. They just wrote them all down. And the answer choices that were given were also pretty much all of these. Age, being in the cold temperatures, FHX, what is this? FHX. Female history? I'm not sure what FHX might have been. I didn't have much space, so I just wrote FHX, but I can't remember what that was supposed to be. Oh, family history. Family history, yep. Sex, and then smoking, or weight exercise. Which of these things is the most significant risk factor for osteoarthritis? Well, it was age, simply because you have to remember this is a mechanical wear and tear thing. So the longer you wear and tear, the higher the risk of osteoarthritis, right? So that means age. The older the person is, they've had a long time of wear and tear, osteoarthritis can occur. Osteoarthritis usually appears insidiously as a phenomenon of aging. Insidiously always means slowly creeping up on you. It's extremely scary. There was a very nice horror movie called Insidious, which is where I actually learned what this word meant. And that movie was pretty scary. Right, so insidiously. I didn't really know what this word meant until I watched that movie, which was a long time ago before med school. And then whenever I see this word in med school stuff, I'm like, oh, I know what that means. It's a slow onset. This word actually is a word that a lot of people don't know what it means, especially people coming from other countries where English isn't their primary language. So very important to make sure you catch this, and I wanted to make sure I put this in the recording too for future students to get that. Right? Insidiously means it's very slow and scary onset, right? It doesn't occur acutely. It's the exact opposite of acutely, if anything. Smoking is actually not a risk factor. As you can see, it's not written here either, for osteoarthritis. And exercise would help. Exercise would help, right? Joint trauma, such as injury to the scaphoid bone from a fall, can predispose to osteoarthritis of the joint. This is one major predisposing factor that is different between osteoarthritis and rheumatoid arthritis. Joint trauma doesn't mean shit in rheumatoid arthritis. Alright? Presentation. So now you have your hand that I put here to help understand where the specific joints we're talking about are. Right? So you have your distal interphalangeal joints all the way at the end of the fingers. Proximal interphalangeal joints, which is more proximal. Metacarpal phalangeal joints, which is actually right at the joint. This is where your palm is, basically. Right, so this is coming right from the palm. Remember that when you have your hand in front of you, you have the entire palm, the beginning of the fingers, and then you have 1, 2, 3 creases. Right? So those are your 3 creases of all your fingers. Your thumb should only have 2 joints. Right? So that's kind of what you're looking at here. Great picture to help understand what's happening, right? They labeled it all pretty well. Metacarpals are where your fingers start coming off of your palm. Right? This is the carpo-metacarpal joint. Now, what's different between these two guys? Well, let's look at the presentation first. The presentation: pain and weight-bearing joints after use, improving with rest, asymmetric joint involvement. Knee cartilage loss begins medially, which is why you'll have a bow-legged knee. No systemic symptoms. No systemic symptoms is probably the number one big difference between the two, because rheumatoid arthritis is an autoimmune systemic problem. So there are many systemic symptoms in that one. But bow-legged. So this is something that wasn't mentioned in CK. Knee cartilage loss. So if you look at this image right here, normal versus osteoarthritis, the knee cartilage loss is starting medially. Right? So you can see that's what they're medially. Right? It's starting from the inside out. Right, so these people end up being very bow-legged. The bow-legging very similar to the same bow-legging you get in infants with vitamin D deficiency, the rickets thing. Now, joint finding. Osteophytes, which are bone spurs, joint space narrowing with subchondral sclerosis and cysts, all of which was given in that x-ray we just looked at, but chances are you weren't able to really identify it, so I will show it to you. I'll point it all out. Synovial fluid inflammatory is non-inflammatory, right? Synovial fluid analysis, if you do a joint aspiration, it should be non-inflammatory, where it's going to fall into the category that we just looked at right here, non-inflammatory. Right, so one of the key things here was that your white blood cell is going to be less than 200. It's going to be very similar. Right, it's going to be less than this excessively high one, where it's more than 1,000. Right, and then of course there's going to be no neutrophils either. It's non-inflammatory. That's what you're going to see in osteoarthritis. Non-inflammatory synovial fluid. And what are the specific areas that get messed up? And we're going to see this difference here. There's development of Heberden nodes and Bouchard nodes, and involvement of the CMC but not the MCP. Heberden and Bouchard nodes look like this. And so you can see how it's kind of got this like weird bony development that's occurring, right? Very strange. These are bony developments on the finger. Inside the bone is developing and is pushing the skin out, right? This is something you do not see at all in rheumatoid arthritis. Look at the hand of rheumatoid patients. What you see in them are swan neck and boutonniere deformations. But there's no bone development. Right? There's no weird bone development or anything like that. The finger is deformed, like a swan's neck, but not really having any weird bone development. So right away you could tell that you should be able to develop a high suspicion for one or the other just by looking at the hands of the patient. Right? Now these joints that are involved, so Heberden high involves DIP and Bouchard is below, it involves PIP. So basically the first two areas are involved in osteoarthritis. And we see that, I circled it, the first two areas are involved in osteoarthritis, in these patients, osteoarthritis. Right, number one, number two, distal and proximal interphalangeal joints are involved in osteoarthritis. And that's really easy to remember because you can just imagine that these people were doing jobs that involved their hands and using very articulate things non-stop, using their fingers for doing very articulate occupational tasks where they heavily overused these parts of their fingers in doing that task. Okay? And of course it also involves the CMC, which is right here, off the palm. Right off of the palm. Right? Right off of the palm is your CMC. What's not involved is the MCP. MCP is going to be clear. So right after the first part of your fingers, that area is going to be perfectly fine. Right, so very, very important to get this down, because you're going to have to use this oftentimes to pick osteo versus rheumatoid arthritis. Remember that although there are many differences between the two, your question is not going to list out everything. Your question is going to list out 2 things, maybe 3, and then just based off of those 2 to 3 things, you have to figure out osteo versus rheumatoid. So if all they're really talking about is this stuff, then you don't need to know anything else. So if you look at rheumatoid, rheumatoid does involve the MCP. So you see how I put an arrow for everything that was involved on the left and was not involved on the right. But the right stuff, this is actually involved in rheumatoid, MCP, PIP, wrist, not the distal or first CMC. So basically all I remember is the distal is not involved. The distal is not involved in rheumatoid. Rheumatoid arthritis, the DIP is not involved because rheumatoid is actually an inflammatory condition due to autoimmune disease, which means that if it's something inflammatory in your body, it has to get into your blood and has to come all the way here, and it just doesn't make it. That's kind of the story I made up in my head. The blood just won't bring everything inflammatory all the way over there. It just brings it up to here and stops, and all the inflammation occurs. All right. So that's one thing I can think of that I made up. The other thing I used to think of was that these people are not doing extremely articulate things, so they don't need the articulate actions of their distal interphalangeal joints to actually do any of these occupational tasks, which is why their DIP is not involved. Right? But rheumatoid arthritis does not involve the DIP at all. Right? And osteoarthritis does not involve the MCP. Okay? So as long as you can remember these things, and then the fact that there are deformities, right? Even cervical subluxation, this actually gets tested. Cervical subluxation in the neck, which can actually end up causing a lot of neck pain and even compression of some arteries coming down from, or nerves coming down from the brain. All right. Cervical subluxation, ulnar finger deviation, swan neck formation, boutonniere formation, all of these are things. Ulnar finger deviation, you can kind of almost see it in this image. Their ulnar finger deviates towards the lateral side. So their ulnar finger, their pinky kind of deviates outwards because of the way it's bending. All right. I think that's really it for the major differences between the two. And as we said, systemic symptoms, right? A lot of systemic symptoms in rheumatoid. Right, so make sure that you can confidently differentiate between them. Now, when it comes to treatment, we just saw the treatment for osteoarthritis, right? Basically these things. The activity modification, acetaminophen, NSAIDs, and intra-articular glucocorticoids. Rheumatoid, though, is an inflammatory condition, so there's other things you could use here too. There's these DMARDs, disease-modifying agents, methotrexate, sulfasalazine, hydroxychloroquine, leflunomide, right? And then, of course, TNF-alpha inhibitors like infliximab, where you have to be careful to first check them with the PPD, right? Because if they have a latent TB, you don't want to give them a TNF-alpha inhibitor. But the disease-modifying agents are the mainstay of treatment for rheumatoid arthritis, because you can't take lifelong NSAIDs or lifelong glucocorticoids like prednisone. You can't do that, right? That's going to be pretty bad. But disease-modifying agents you can take for life. These reduce long-term joint destruction and take more than 6 weeks to actually kick in. Short-term treatment with glucocorticoids or NSAIDs can provide rapid temporary relief before the DMARDs kick in. And this fact is actually very critical, because you can get a question where they'll put all of these as answer choices, and they'll ask you what you should give to the patient for immediate relief. For immediate relief, you would have to pick between NSAID and glucocorticoid. And if they have renal or peptic ulcer disease, you would just pick the glucocorticoid, not the NSAID. So you can see how questions can have everything as an answer choice. But since they want immediate release, you don't pick the disease-modifying agent. And since your patient might have renal failure or peptic ulcer disease, you don't pick the NSAID, so you just give them glucocorticoids and the disease-modifying agent, and then the glucocorticoid will fix them up immediately, but the disease-modifying agent will kick in 6 weeks. So you can taper them off, right? Prednisone is a 1-month course. You take 1 tablet a day for the first week, 2 tablets a day the second week, 3 tablets a day for the third week, and then you start working your way back down to 2 tablets a day for the 5th week, and so on and so on. Right, so in the 6-week period, you can give them glucocorticoids where they can go upwards and back down and taper it off, and then the disease-modifying agents will kick in that much time. All right. The last thing to talk about here are some of these extra-articular manifestations, the big asterisk, that occur in rheumatoid arthritis. Right, so you have your rheumatoid nodules, which are fibrinoid necrosis with palisading histiocytes in the subcutaneous tissue, and lung. So now you can get a question that starts off at the lung, but is actually a rheumatoid arthritis question. That's Kaplan syndrome with the C. Right? Pneumoconiosis and rheumatoid arthritis, that's Kaplan syndrome. So if you have a patient who has these lung problems and then they also have these bone problems, and then they ask you what is their bone problem, is rheumatoid arthritis. You could also have someone who gets pericarditis, pleuritis, interstitial lung disease, even the anemia of chronic disease, because this is a chronic disease. So they're going to have what may look like iron deficiency, but it's not iron deficiency because their ferritin is going to be high, right? Neutropenia and splenomegaly, that's Felty syndrome. So if you have rheumatoid arthritis, you can actually get neutropenia and splenomegaly, where everything went into the spleen, and that's why you have splenomegaly. So Felty syndrome can occur. All right. Double A amyloidosis can occur, Sjogren's syndrome, scleritis, even carpal tunnel syndrome. So many different things that are related to rheumatoid that rheumatoid ends up becoming an amazing thing to ask multiple questions on for step 2 and especially step 1. All right. So that's basically it here. Let me see if there's anything else to ask. This question refers to a very specific thing which is mentioned in this area here, the anti-cyclic citrullinated peptide antibody, which is specific to rheumatoid. So this is a rheumatoid patient. It says a 47-year-old woman comes to a physician with progressive joint pain and swelling in her hands for the past several months. So progressive joint pain and swelling, several months. Okay, so it's been a long time. She also has fatigability that gradually worsened over the same period. Morning activities are especially difficult due to stiffness lasting 1 to 2 hours. So she has long morning stiffness. We just said in osteoarthritis, when we looked at it in step 2 CK book, that the morning stiffness only lasts about less than 30 minutes. Basically, the way I had it memorized, I was a little shocked to read this here because I'm always shocked every time I see it here. But the way I have it memorized is that osteoarthritis doesn't have morning stiffness, rheumatoid arthritis does. Right? Because osteoarthritis is one that improves with rest. So when you're done resting and you wake up in the morning, you feel great. So you don't need to worry about the morning stiffness thing here. But rheumatoid arthritis is autoimmune. And as your day goes on, it actually gets better when you do use this. See, they tell you here, pain, swelling, and morning stiffness lasting more than 1 hour and improving with use. Right? Of course, osteoarthritis gets worse with use because that's what it is. It's a wear and tear problem. Rheumatoid arthritis gets better with use. So this woman has morning activities that are very difficult because of stiffness lasting almost 2 hours after. This is supposed to be after waking, not walking. Examination shows warmth, swelling, and tenderness involving the PIP joints, MCP joints, and wrists bilaterally. The fact that it involves the MCP kind of gave away its rheumatoid arthritis, right? And it's bilateral. It doesn't really have to be bilateral with osteoarthritis. Right? With osteoarthritis, it doesn't have to be bilateral. So I know it is in this image here, but this image is just here to show you the exact places things happen in. But osteoarthritis, since it's not a systemic thing and it's not an autoimmune thing, it doesn't have to be bilateral. Right? But rheumatoid is systemic and autoimmune, so it affects the whole body equally. Autoantibodies against what is the most specific for this patient's condition, and that was the citrullinated peptides, most specific. Right? That's it. That's all this question was. Tissue inflammation causes arginine residues in proteins like vimentin to be enzymatically converted into citrulline via citrullination. Right? That's why you get the arginine becoming citrulline, and then you make anti-citrulline antibodies because you don't recognize that citrulline. Right? So that wraps up rheumatoid as well. And then I want to look at the questions that, wait, what are these? Yeah, and look at the questions they have here. So This one here says 55-year-old man with a history of prostate cancer presents with lower back pain and bilateral leg weakness. On exam, he is found to have point tenderness on the lumbar spine and decreased sensation in his legs. What's the best next step? Well, it looks like the prostate cancer must have metastasized to his lower back, so we should check that out. Right, we should check that out. So here they tell you, give steroids to relieve the spinal cord compression resulting from likely bone metastasis, and check it out with MRI. MRI is the best study, but preventing permanent neurologic disability is the priority. Remember to consider multiple myeloma, which can present almost identically. Right, so the next best step could have both answer choices: do an MRI or give steroids. And the correct answer to pick would be to give the steroids. Right, give the steroids because you want to stop the worsening of this decreased sensation that he's developing, because something must be getting compressed. That lumbar plexus of nerves is probably being compressed with his lower back lumbar involvement of the prostate cancer metastasis. Here you have a young 15-year-old boy presents, oh, they didn't say boy, youth, presents with several months history of pain in the upper part of his thigh. Okay, so it's a 15-year-old boy with upper thigh pain. The pain is worse at night. A plain film shows small nidus of lucency. What over-the-counter remedy is indicated? So small nidus of lucency, so small area of see-throughness is occurring. What's the immediate cancer that comes to mind, and then how would you treat it? Well, this adolescent patient is likely presenting with an osteoid osteoma, a benign bone-forming tumor characterized by prostaglandin formation. Relief of pain is thus often achieved with NSAIDs. Tumors may self-resolve, but surgical removal of the nidus may be necessary for symptom relief. And this is a very high-yield topic, the osteoid osteoma. Right, small nidus. So if we go back and look at it one more time, oh no, the pictures were actually in the first aid step 1. Let me go back to that. Oh, and we have to look at this too. Osteoid osteoma. Yeah. So the small nidus here was the, let me see how much, no, I did too much. So the small nidus was the area that was right here, this thing, right, this thing right there. And what they could have done in your question right now was that they could have said that the nidus is in the cortex. They didn't say that, right? Plain film shows small nidus of lucency, yeah. But the age that they gave and the fact that there's pain and the pain is worse at night was all supposed to be the main indicators of the fact that this is most likely osteoid osteoma. Right? Osteoid osteoma is where you're developing new bone. Right? New bone is being made in that cartilaginous area of the cortex. There's another question here that I recently got from one of my students that shared their Kaplan Q bank so we can study together, or I help him study for his step 2. This one says a 14-year-old boy has pain in his proximal left tibia. So again, look at the age again, same range, 14, 15. Pain began 3 weeks earlier and was not associated with any trauma. Pain is worse at night and is substantially relieved by aspirin and NSAID. There is point tenderness of the proximal tibia. There is no erythema, swelling, or abnormal warmth. Radiograph reveals a 3 mm sharply demarcated round radiolucent area with the cortex of the proximal tibia. So this question gives you a lot more than, these questions here are not very realistic. They're just here to teach you, and that's nice. That's fine. It's not how your step questions are going to look like, though. This is more how your step questions are going to look like, and this is osteoid osteoma. Everything fits. Worse at night, aspirin helps, it's radiolucent, it's on the cortex. Osteoid osteoma. Give NSAIDs. That's it. Alright? So this is a very high thing. Now here, this person with your osteoarthritis. Remember, osteoarthritis involved the distal interphalangeal joints and the proximal interphalangeal joints, right? But did not involve the MCP. And if we look here, in all of these fingers actually, in all the fingers, these areas are looking a little wider than they need to, because there's actually really bad inflammation there. They're developing extra bone, and if you were to actually look at their hand, like not the X-ray version, but their actual hand, you would see the Bouchard, the Bouchard and the Heberden nodes. That's what those are. Okay, and then they mentioned you're supposed to see joint space narrowing. Joint space narrowing. So the only place with joint spaces really are these joints right here where the fingers are supposed to move, and you can see that there's not much space in between here in all of them, right? Like right here it actually looks like it's stuck together now, right? So that's your joint space narrowing. And then the osteophytes, these are supposed to be little bone caps almost that are sticking out. And I believe the most clear osteophyte was, let me just check something real quick one more time. Yeah, PIP, DIP, right? And the first CMC. So yeah, the osteophytes are not that clear. Not that clear. It's supposed to be things like this, but this can't really be it because this is your MCP, which is not involved in osteoarthritis. Yeah, I don't really see any other osteophytes per se in this image. But the cysting that they're saying, subchondral degenerative cysts, that's what you're seeing in the same circles as well. That involve the DIP and PIP, that's in these guys. Right? So that's generally all there is to it. Point is, as soon as you see that the DIP and the PIP are involved, remember that rheumatoid arthritis doesn't involve the dip at all, so the DIP should look completely normal and clear, but all the DIPs in this person are extra messed up. There's like barely any space in here. They probably can't even really bend their fingers very well. They can't bend their fingers extremely well at all. To make a closed fist would be very hard for these people because of the joint space narrowing and the extra inflammation and development of bone in the DIP and PIP. Right? And I think that's it for today. And then tomorrow we'll move on from here to osteoporosis, more neuroma, and gout, and a couple other things that are left here. And for the osteoporosis stuff, we'll have to go back to the endocrinology chapter and look at osteoporosis versus osteoarthritis. Alright, so thanks a lot for joining today, guys, and I'll see you tomorrow morning.